Hello everyone, this is Dr. Sangeeta Chaudhary. Once again, I welcome everyone to my channel. I am an MD in General Medicine. So many of you have asked me to make a class on auscultatory finding of respiratory system. So here today I am making a class and I will discuss all about the auscultatory findings and how we start doing auscultation. So how to do auscultation in a patient, okay, with respiratory disorders or any patient where we want to do a respiratory system examination. Patient should be sitting upright. The position is very important. So preferably if the patient can sit up, patient should be sitting upright. We start doing auscultation with the diaphragm of the stethoscope. We do it from top to bottom and we do it as per the anatomical areas of the chest. So anteriorly we do supraclavicular area, infraclavicular area and mammary area. Laterally we do on axillary and infraaxillary region or area, and posteriorly at the back we do auscultation in the interscapular and infrascapular area. So these are the anatomical areas or regions of the chest where we do auscultation. And always remember that जब हम auscultation करते हैं we need to compare it bilaterally, right? Come from above downwards and always keep on comparing the sides, both sides of the chest wall. Okay, now coming to the findings, what are the findings we should discuss about when we auscultate the respiratory system? First of all, breath sounds. Next thing is added sound, and last thing is vocal resonance. So let's come to the breath sounds first. Okay, so what are the normal breath sounds? We have mainly two types of breath sounds, that is vesicular breath sounds and bronchial breath sounds, and sometimes there is a third variety known as bronchovesicular breath sound. Now what is vesicular breath sound? Vesicular breath sound, it is a soft low pitched sound with rustling character. Rustling character means rustling of leaves, it gives a sound. So that sound is known as rustling. So rustling character, soft low pitched sound. And in vesicular breath sound, inspiration is longer than the expiration. The ratio of inspiration and expiration being 2:1. And there is no gap in between inspiration and expiration. That means it is a continuous sound, no pause or no gap in between. Vesicular breath sound is heard almost all over the lung field, mainly the peripheral lung field. We get to hear the normal vesicular breath sound. Next variety is bronchial breath sound. Now how it is different from the vesicular breath sound? Bronchial breath sound is loud, it is high pitched, it has a hollow character. The bronchial breath sound, in the bronchial breath sound, the expiration is longer than the inspiration, and the ratio of inspiration and expiration being 1:2. And there is a definite gap between inspiration and expiration. Okay, and bronchial breath sound is normally heard over the trachea and manubrium. But if bronchial breath sound is heard in the peripheral lung field, that means there is some abnormality, because in the peripheral lung field, vesicular breath sound is the normal breath sound. But instead of vesicular breath sound, if you're hearing bronchial breath sound in the peripheral lung field, that means there could either be consolidation, there could be fibrosis, there could be collapse, there could be cavity. So some or the other pathology will be there in the peripheral lung field if you get to hear the bronchial breath sound in peripheral lung field. Now there is another variety I told, bronchovesicular breath sound. As the name suggests, the character of bronchovesicular breath sound is a mixture of vesicular and bronchial breath sound. Here the inspiration and expiration, duration of inspiration and expiration is equal. Okay, and it is of medium pitch, okay, and of intermediate intensity, right? So it has some character of both the bronchial and the vesicular breath sound. That is why it is known as bronchovesicular breath sounds. Now as I was describing bronchial breath sounds again has three subtypes. So if you're getting a bronchial breath sounds, try to identify which subtype it is. There are three subtypes. One is tubular, one is cavernous, one is amphoric bronchial breath sounds. The first one, the tubular bronchial breath sound, is the classical bronchial breath sound, where it will be of high pitched loud sound with a tubular character, and there will be a definite gap between the inspiration and expiration being longer than the inspiration. So all the classical features will be there in tubular bronchial breath sounds, and you get to hear tubular bronchial breath sounds mainly in cases of consolidation, then collapse with patent bronchus, right? Next is cavernous. Cavernous variety of bronchial breath sound. It is of low pitched sound. It's a soft sound, low pitched, and then you get to hear it in superficial cavity with a smooth wall. For example, you get to hear this over a tubercular cavity or an abscess cavity. Okay, so this is about cavernous bronchial breath sound. The last variety is amphoric bronchial breath sound. Now this is a metallic sound with an echoing character, right? Metallic sound with an echoing character. Okay, this is known as amphoric bronchial breathing, and you get to hear this in cases of large cavity with a rigid wall, or sometimes in cases of tension pneumothorax with a leak, air leak, means tension pneumothorax with a bronchopleural fistula. So this is about amphoric bronchial breathing. So we have discussed about subtypes of bronchial breathing, that is tubular, cavernous and amphoric type. So this is all about the breath sounds. Okay, so whenever you are auscultating, you need to tell your findings. Okay, which bronchial, which type of breath sounds you're getting to hear, what is the character, what is the pitch, okay, if there is any abnormality, and all those things you need to discuss and present, right? The next thing is added sounds. So there are few added sounds in the auscultatory findings of lungs which we may get. First of all, crackles. Okay, crackles are short explosive sound. They are non-continuous, they are non-musical. Okay, short explosive non-musical sounds are known as crackles. Why crackles are produced? Crackles are produced because of sudden opening of the collapsed alveoli, or else because of passage of air through the smaller airways which is filled with secretions, right? So these are the causes or mechanisms for crackles. Now crackles again can be of two variety: fine crackles and coarse crackles. The fine crackles, it is of high pitch in quality and it is very brief, whereas coarse crackles, they are of low pitched and the duration of coarse crackles are a little longer than the fine crackles. Fine crackles, they are usually heard at later part of inspiration, whereas coarse crackles, they are usually heard at the earlier part of inspiration. So where do you get to hear fine crackles? You get to hear in cases of pulmonary fibrosis and early stages of pulmonary edema. Where you get to hear coarse crackles? Coarse crackles you get to hear in cases of pneumonia like consolidation, okay, and pulmonary edema also. Okay, so this is about the crackles. Next comes wheeze. What is wheeze? Wheeze is a high pitched sound. It is continuous sound and it is of musical nature. Okay, so it is a continuous sound, it is of high pitched and it is of musical nature. Why wheeze is produced? Wheeze is produced due to narrowing of the airways. Okay, so it can be produced most of the time it is expiratory sound, expiratory added sound, whereas I told you the crackles are mostly during inspiration, either early inspiration or during later part of the inspiration, whereas wheeze is most of the time it is expiratory sound, right? For example, wheeze can be seen in cases of obstructive airway disease like bronchial asthma, chronic obstructive pulmonary disease like COPD. Okay, so this is about wheeze. Next is rhonchi. Now, what is rhonchi? Rhonchi, again, it is a loud sound. It's like the sound is like snoring. Okay, it's loud snoring sound, and it is heard due to secretions in the larger airways. Okay, for example, in cases of bronchitis, there will be excessive secretion in cases of bronchitis. So in cases of bronchitis, you get to hear this rhonchi. Lastly, stridor. What is stridor? Stridor It's a loud high pitched sound, and it is produced due to obstruction in the larger airways. Okay, stridor is mainly inspiratory. Okay, it is an inspiratory sound, and you get to hear stridor in cases of croup or epiglottitis, or if there is any laryngeal edema resulting in obstruction, or if there is any large foreign body which is causing obstruction in the larger airways. So these are the causes which will produce the loud sound which is known as stridor, loud inspiratory sound which is known as stridor. So these are the added sounds, okay, which we need to discuss. If there is any presence of any added sound, we need to present it, okay, we need to say about it, we need to discuss about it. Lastly, the last auscultatory finding what we discuss is vocal resonance. Now, what is actually vocal resonance? Vocal resonance means when somebody speaks, the spoken sound will be transmitted into the chest wall through the lung parenchyma, and it is audible with the stethoscope. Okay, this is what vocal resonance is. Vocal resonance is important because there are pathological conditions where vocal resonance will increase. There are conditions where vocal resonance will decrease. For example, vocal resonance will be increased in cases of consolidation, in cases of fibrosis, in cases of at the upper level of pleural effusion, in cases of collapse with patent bronchus. So these are the conditions where vocal resonance will increase. Which conditions vocal resonance will decrease? Vocal resonance will decrease in conditions like pleural effusion, pneumothorax, massive emphysema, if there is a cavity without a patent bronchus, okay, or if the patient is having a thick chest wall or obese patient. So in these conditions, vocal resonance will be reduced. So depending on the vocal resonance findings, we can think of some pathologies, okay, underlying pathology we can think of. Now, vocal resonance, it again has three subtypes we can say, or three different characters. First of all, bronchophony. Now, what is bronchophony? We will ask the patient to repeat the word like 99 or 123, 123, 123, 99, 99, like this. The patient will repeat, and we will hear the vocal resonance with the stethoscope. Normally, when patient repeats the phrases like 99, 123, the sound should be muffled. But if it is heard very clear and loud, that means the bronchophony is present. Okay. So where do we get bronchophony? We get in cases of consolidation. We can get in cases of, cavity with in cases of cavity with a patent bronchus. We can get. Okay. So these are conditions, and of course at the level of upper level of pleural effusion, at the upper border of pleural effusion, we can get this bronchophony. Next is egophony. What is egophony? If we ask the patient to say E, we will hear it as A. Means there is a nasal bleating quality of the sound produced. This is known as egophony. Egophony is again found at the upper level of pleural effusion. Okay. Lastly, whispering pectriloquy. Now, what is whispering pectriloquy? We will ask the patient to whisper 1, 2, 3, 1, 2, 3. Okay. Normally, it is not audible, or it is audible with a very less intensity. But if it is heard sharp and distinct, as if somebody is whispering right at the examiner's ear, that means the whispering pectriloquy is present. Okay. So there are conditions like consolidation or maybe fibrosis where there will be presence of whispering pectriloquy. Okay. So this is all about the vocal resonance. We have discussed about breath sounds, different breath sounds and their characters and quality. We have discussed about various added sounds, okay, and their implications in clinical practice, and we also have discussed about vocal resonance, okay, and their implication of vocal resonance in identifying lung pathology. Okay, so this is all about auscultation of the respiratory system. Okay, you discuss about these findings. Okay, you try to look for these findings in a particular patient, and then you write it down, and then you try to think and discuss and then make a diagnosis out of it. Okay, so thank you so much. I'm sure this class will be helpful. Thank you.